Good afternoon, everybody. I'm Harvey Milkman, professor, Department of Psychology, Metropolitan State University of Denver. It's an honor to be here. My perspective is from an international perspective and more from a prevention perspective. I guess you could summarize my talk by saying I'd rather build a child than repair an adult. But there's some really great intersection of what the speakers have been talking about today in the way of a public health model. So I'm going to talk about Europe and the United States in terms of the benefits of a public health approach rather than a criminal justice approach to this problem of drug abuse. This is a familiar chart, I think, to everybody. You can see Kentucky is the second highest in the nation in terms of deaths per 100,000 and overdoses. There's an interesting models that are going around now. I'm going to talk a little bit about in Portugal. They've decriminalized all the drugs for low-level dealers and low-level users, and they have become the lowest in Europe in terms of deaths per 100,000. The figure you see there is less than one person per 100,000, and you can see here in the United States we have 312 deaths per 100,000 people related to overdose. So the decriminalization approach, people are talking all over the world now about the Portuguese model. If you read the New York Times yesterday, you can see the how to win the drug war is not by increasing criminal penalties, but really looking at the kinds of things we've been talking about, reaching out, helping people, making treatment available to people, and they've been enormously successful in Portugal with this approach. Another model, and this is something that I've been working with Iceland for the last 20 years, and look at the statistics here. We've been able to reduce teenage substance abuse from the highest in Europe to the lowest in Europe in a 20-year period. And we've been doing that by reaching out to children through a prevention model. So prevention is key. That's really what brings me here to talk about. But you can see here in 1998, 42% of the kids were getting drunk, seniors within the last 30 days, and now it's down to 5%. And the same kinds of trends with cigarette smoking and with cannabis use. So this is an amazing outcome, and I'm going to talk a little bit about how some of my work has contributed to that approach. Go back to the early 70s. I was a young psychology intern at Bellevue Psychiatric Hospital in New York, arguably one of the most interesting and important teaching hospitals in the country. And we gave people their drugs of choice. We gave heroin users morphine, and we gave amphetamine users amphetamine, and we interested in why were they using the drugs in the first place. And we found out that people were using the drugs to complement their characteristic way of reducing stress. So a person who would use amphetamine was naturally inclined towards hyperactivity, extroversion, intense sort of confrontational approach to the world, and wanting to step up their energy level when they were under stress. The heroin users wanted to shut down stimulation. So what we discovered was that people were getting addicted not only to the drugs, but to self-induced changes in their brain chemistry. The problem is really bigger than drugs. It's about coping with stress. And so we coined this term. I was working with Stanley Sunderworth, a noted brain scientist, and we redefined addiction really as self-induced changes in brain chemistry that result in problem behaviors. And when you look at that, you're looking more at the style of coping rather than the specific drug. Well, it almost came like a kind of a epiphany in the middle of the night when I said, well, what's the opposite of that? And we started talking about natural highs, that we could have really a social movement around having, if people want to change their brain chemistry, which obviously they do, why don't we have when we know all about dopamine and serotonin and GABA and norepinephrine, why not harness these chemicals to change brain chemistry in positive ways? So I was awarded $2 million from the Center for Substance Abuse Prevention to offer natural highs to teenagers. And I wrote some books about that. This is the second edition of my book called Craving for Ecstasy and Natural Highs. And we talked about how do you get well, sports is one thing. We talked about winning and losing in sports here in this arena. But also, there are a lot of people who don't want to do sports. And if you look at Dan Goldman's work on positive addictions and emotional intelligence, and you look at the ideas about what do people really enjoy, well, the humanities and the arts have to come into play. So we founded a program, with Cleo Parker Robinson Dance, an African-American dance company. Cleo is a legendary African-American dance choreographer. And we offered kids artistic alternatives to drugs and crime. We had 2,000 kids run through that program, and from 1993 to 2003, and we had some really positive results. Well, it's no secret that kids can do drugs and also do art, but then we also gave them a very rigorous life skills curriculum along with that. So meet them where they're at and take them where they don't want to go, which is really kind of what we did. This is one of the kids who was one of the artists. He coined this phrase. He came out of the art class one day, Jamon, and he said, Harvey, it's dope, it's dope. And I knew exactly what he meant. The art class was really replacing his desire to take drugs. And so these are the kind of results we had. We had improvement in family, significant. We measured it scientifically. Mental health was better. Response to negative peers was diminished significantly. Deviancy, less crime, less drug use. So we had tremendous results. So we started talking to Iceland about this. And in Iceland, you can see the numbers. The figures were very high. Drunk in the past 30 days, 42% in 1998. Now it's down to 7%. Daily smoking, 23%, down to 3%. That's really an amazing sort of figure. I'm thinking about how many people we talked about cigarette addiction here in this room. Drug use in the United States is nowhere near the kinds of statistics we've achieved in Iceland. So really, how did it happen? Well, we used to have this approach where the researchers, and I think some of you have been frustrated by this, research would go on, nobody would pay attention to it. And the policymakers would have they didn't really pay attention to the research, and the practitioners were sort of guided by, they didn't have any direction in how they would guide it. Well, I interviewed the mayor of Reykjavik. Half the population of Iceland is in Reykjavik. And he's a physician. He said, I'm not doing anything without research. I don't make any kind of public policies without research. So now they decided in 1998 that we're going to have research as guiding policy and practice. And that's really what they do, is an ongoing dialogue between research, policy, and practice. And so what we do here is what we've discovered. We've collected data over a 30-year period. Iceland is the most data-rich country in the world. We have 500 data points on every kid born in Iceland since 2002. And so these are the factors that really contribute across cultures: family factors, peer group effects, general well-being, extracurricular activities. These are the things that either make or break the deal for kids. And so these are both risk and protective factors. And some people get mystified by these ideas about what they have to memorize a whole encyclopedia of risk or resiliency factors. But the opposite of a risk factor is a resiliency factor, right? So if any one of these things is strong, it reduces substance abuse. If they're weak, they increase substance use. So we analyzed it deeper from the data we collected. We do survey data. Every kid has a survey in Iceland and goes through this process of discussing these kinds of elements: the time spent with parents, positive and negative effects, how as parents we approach the peer group, staying outside late, hanging out in malls, inside and outside school, bullying, organized activities. And so what we've done in Iceland, we started a leisure card activity. So every kid in Iceland gets $250 provided by the government to sign up in a leisure time activity: art, music, dance, poetry, whatever they want, sports. And then there's a kind of a community buzz around that everybody understands that that's a good thing for their kids. So they enroll their kids in these programs. This has been done now in 18 different countries in Europe. We have a model where you can see here all these countries, 39 different municipalities have been participating in the Iceland model. So just to sort of food for thought, we talked about the Portuguese model of really focusing on treatment and making help available to people rather than the criminal approach. And here we have the Iceland model is being used in all these different countries to try and institute a prevention approach. So now we've had these tremendous results. So kids from the age of 10 all the way up to 18 are surveyed. The important thing is the survey. You can see here how many different countries and we've answered over 9 million questions have been answered by the kids, and it's easily transferable. So this model, I just came back from Ecuador. We're talking to Waterloo, Canada, and we've just been talking in Arizona, and now the Boulder County Health Department is looking at using this Iceland model. So the to-do list. First thing is map the situation. So I think the genius of the Iceland model is thinking about doing it locally. So it's like fresh vegetables, we say in Iceland. The data has to be fresh and it has to be local. So and it has to be have to give it to people. So the researchers can't keep the data and not make it available to the people who are working with kids. Map the situation, the local conditions. So the conditions in, let's say, Lexington might be very different from the conditions in Louisville or different from another. So the data has to be local, and then find the local risk and protective factors. Address these factors through local community work. Form local networks from all institutions in the municipality. Give immediate practical information out quickly. Measure regularly and frequently. And so when we do that and we have this dialogue between research, practice, and the people who are making policy, and then the community decides on what are their resources. So I had a program that probably should have gone internationally, but you know what? They didn't have a Harvey Milkman in, let's say, New Finland. They didn't have a Cleo Parker Robinson. So what does the community have? And then we work with individual communities, and then we find out what their risk and resiliency factors are, and then we get the kind of results that we're talking about. So local, remember that, fresh vegetables. The research has to be fresh, it has to be local, and then the communities come up with their own solutions in terms of what can be done in their particular areas. Thank you.